I've been tasked with presenting a case of body-identical hormone therapy and how we might use it to optimize the treatment of the woman that we would typically see in our clinic. So I'm going to present a case study and some of the rationale behind the way we would manage these cases. So the lady is a 50-year young lawyer. I don't use the term old too much if I can avoid it. Presenting with erratic periods, vasomotor symptoms, hot flushes, sweats, trouble sleeping, poor energy, low libido, recent weight gain. I'm sure you recognize the scenario. Past medical history of migraines, but no aura and no neurological symptoms. Her mother had an unprovoked venous thromboembolism, but she had thrombophilia testing, and there was no thrombophilic factor found. Her sister suffered with hormone receptor positive breast cancer at the age of 50. She's had significant difficulty in concentrating at work, and this is affecting her work as a lawyer. And she was also in the process of seeking divorce from her husband. This is the other form of HRT, husband replacement therapy. And in her past obstetric history, had 2 children with pregnancy-induced hypertension. During the course of her 40s, she had dreadful problems with her periods, and they attempted to treat her by insertion of a Mirena, levonorgestrel intrauterine system. And in her words, she went crazy or loopy. Turns out that she was severely intolerant even to the low doses of systemic progestogen that the Mirena exposes individuals to, and it was removed within 48 hours. A couple of years prior to her attendance to us, she was treated with a sequential combined patch and tablet containing either estradiol and levonorgestrel for the patch or conjugated equine estrogens and MPA for the tablet. But she experienced quite severe premenstrual symptoms and poor skin in the luteal phase, acne. And she didn't find that she had any improvement in her libido with these previous treatments. She stopped treatment, and on the advice of a friend of hers, she attended a compounding bioidentical hormone therapy clinic. At this clinic, she was offered these unregulated, untested combinations of biased with estradiol, estriol, and progesterone testosterone, or triased, 10% estrone, 10% estradiol, and 80% estriol. After discussion and numerous blood tests and also salivary tests, she was commenced on a supposedly individualized regimen of 0.5 milligrams of estradiol, 3 milligrams of estriol, 100 milligrams of progesterone, and 2 milligrams of testosterone in a nice tasting vanilla troche or lozenge. Just a little review. What are bioidentical hormones? These are hormones which are identical to those produced by the human ovary and the adrenal gland. But there has been a significant hype about these as being potentially safer than with conventional hormone therapy, and this is because of the knowledge vacuum and fear post-WHI. And the global consensus, the revised global consensus statement, states quite clearly that the use of these custom compounded hormone therapy regimens is not recommended because of the lack of regulation, rigorous safety and efficacy testing, batch standardization, and lack of purity measures. This poor lady had no symptomatic response to her compounded varieties of bioidentical hormones. Her bleeding was chaotic, and she attended our hormone health menopause clinic for further evaluation. She was found to be obese with a BMI of 30 and an upper limit of normal blood pressure of 158/92. She had low estradiol levels of only 90 picomoles per liter. This is while she was still on the compounded varieties. Low testosterone levels with a low free androgen index of only 0.5% and low progesterone levels. Also borderline low thyroid function tests. She was towards the upper end of insulin levels, so to a certain extent insulin resistant, and also elevated lipid profile with cholesterol of 6 and LDL of 4.1. Her ultrasound was okay, but she still had some functional follicles, and her DEXA scan showed osteopenia. So this woman was switched to regulated body-identical hormones, which are tested and are evidence-based for effectiveness and safety. She was given 2 milligrams of Sandrina estradiol gel, 200 milligrams of utrogestan, which is micronized progesterone, day 17 to day 28, and the preparation that we imported from Australia, Androfen 1% cream, containing 5 milligrams of testosterone per 0.5 mils. And she was also given my inositol in order to reduce her insulin resistance. After counseling, this woman was perfectly happy to use body-identical hormone therapy when it was pointed out to her that the same hormones could be delivered with regulated varieties of hormone therapy, and she did not have to resort to unregulated varieties. And it's possible to achieve this with a variety of gels, including not only the Sandrina, but the estrogel and estradiol patches, and also other types of progesterone, which can be delivered vaginally for those women who are severely progesterone intolerant. Testosterone varieties are possible with using gels, titrated down doses of the male gels, such as Testim gel and Testogel. These are off license in women, but using the correct dose, which is 1/5 to the 10th of the male dose, and keeping the free androgen index below 5%, there isn't a concern about supraphysiological levels and androgenic side effects. The implants are currently unlicensed, but are used by some patients, and Sue Davis will be talking more about androgens tomorrow. So what was the outcome in our case? The woman represented with a more moderate blood pressure of 135/88, a body mass index of 27.6. Her estradiol levels had increased to 280, and her free androgen index had gone up to 2.4%, with progesterone levels in the luteal phase of 11.6 nanomoles. Thyroid function was still borderline low, but was being observed. She was less insulin resistant, and her lipid profile had improved. She found that her periods were much better regulated, they were lighter and shorter. Her vasomotor symptoms had resolved with improvements in insomnia, and she felt that cognitively the lights had come on and she could function much better in her job as a lawyer. And she, generally speaking, had found that her energy, mood, and libido had returned, and her joie de vivre was back. And in fact, she was planning a swim of the English Channel. The ongoing plan was to switch her in the long term to continuous combined progesterone with utrogestan, only breaking for 3 to 4 days if there was a bleed to allow for a period to occur. So the key issues addressed by this case was that this woman with cycle-related symptoms was able to have these moderated through the use of micronized progesterone rather than synthetic progestogens. She found that she was feeling not only better, but also her risk factors were moderated through the use of these body-identical hormones with transdermal estradiol and micronized progesterone, given her complex past medical history and family history. She had a significant improvement in her low sexual desire, and in fact, her divorce was partly brought on by her partner's constant sexual demands. And also she found that the use of micronized progesterone was supported by guidelines in terms of breast cancer risk by various societies. We advised her that the increased risk of breast cancer was associated primarily with the addition of a progestogen to estrogen therapy and related to the duration of use, but 3 studies suggest that micronized progesterone or dydrogesterone could be associated with potentially lower risk than synthetic progestogen. And she felt much more comfortable about that. So, ladies and gentlemen, the benefits of body-identical hormone therapy can be achieved without resorting to unregulated compounded bioidentical hormones. And given current evidence, body-identical, body-similar hormone therapy regimens appear to optimize the benefit-risk ratio for hormone therapy. The recent studies, which Amos Pinas referred to, such as KEEPS and ELITE, using estrogens with micronized progesterone, have demonstrated that the benefits of hormone therapy can be achieved with few adverse effects on surrogate markers, but we still require data from large long-term randomized controlled trials on cardiovascular and breast endpoints to confirm the findings. So I believe that, given the sufficient funding, of course, that the time has come to conduct the study with the right preparation for the right woman for the right indication. Unfortunately, we don't have $1 billion, which is what pretty much the WHI cost to conduct. That's something that we have to work towards, perhaps with the WHO in the future to try and raise this funding. So finally, I'd just like to leave you with an invitation to our International Menopause Society Congress in Vancouver, June 6th to 9th next year. You are all very welcome, and thank you for listening to me.